This is Dr. Vermilio. In this lecture, we will discuss pure tone testing and a paper by Carhart and Jerger. This is a diagram with the keyboard. If you're familiar with the piano, you know that the low frequency sounds are on the left side of the keyboard. The high frequency sounds are on the right side of the keyboard. And as you move from left to right on the keyboard instrument, the note C is doubled in frequency. So here's the note C. When you double the frequency, you get an octave above that for this note C. And then when you double this frequency, you get an octave above that. This is the audiogram. This is the graph that we're going to use to plot the hearing thresholds for pure tone frequencies. And you can see for the x-axis, we have octave pure tone frequencies presented. So there's 250 hertz. We'll double that. That will give us 500 hertz. Double this, that gives us 1,000, etc. There are also a few interoctave frequencies presented. On the y-axis, we have hearing level in dBHL. The levels at the top of the graph represent a very low level, which is analogous to a very soft level. The numbers at the bottom of the graph represent a very high level, which is analogous to a very loud level. So we have the x-axis, the y-axis, so we're plotting frequency versus level. Okay? So we need to keep these things straight. Level, frequency, level, frequency. So every sound has, every pure tone rather, presented in the test has a specified level and frequency. So sounds in our world are generally complex. Each sound is comprised of a fundamental frequency and harmonics. These are sounds in our world. However, the sounds used for a hearing test, a standard hearing test, are called pure tones. This is a graph that shows frequency on the x-axis and amplitude on the y-axis, and this is a spectrum for a pure tone at 526 hertz. 526 hertz. So this would represent an octave above middle C. 526 hertz. Now, if we actually played an equivalent note to that on the piano, this is what it looks like. So here's our tone, which is an octave above middle C on the piano, and notice that we have the energy right around 526 hertz, but then we also have energy at all these other frequencies. This extra energy here is called the harmonic structure of the tone, of the complex tone. This is a subharmonic. So when you go to a piano and you strike a key, you're not eliciting pure tones. You're not producing pure tones. You are producing complex tones. Now, any complex tones may be divided up into pure tone components. But for pure tones, all you see is the energy right around 526 hertz. Carhart and Jerger in 1959 wrote a paper that described a protocol for measuring pure tone thresholds. The audiometer was created in, the first one was manufactured in 1922, created by Dr. Harvey Fletcher and colleagues at Western Electric, and they distributed an audiometer, but it really didn't come with really good instructions on how to do the test. So imagine all these clinicians all over the country using an audiometer that's producing pure tones, and they have, each clinic might have a slightly different version of the protocol. Basically, they're making it up. So Doctors Carhart and Jerger decided, you know what, let's go ahead and standardize a protocol. That way, when we look at test results from one clinic to the next, or one session to the next, or one test date to the next, we can actually make some reasonable comparisons across test results. Otherwise, if you have different protocols, you cannot make direct comparisons. So the purpose of the paper was to urge clinicians to standardize threshold testing procedures. They had a brief description of an improved version of the Houston-Westlake technique. They have a review of features of auditory behavior which determine the suitability of this method. And they had a report of an experimental comparison between this method and 2 other procedures in the Carhart and Jurger paper. They specified that the tone, the pure tone, should be clearly audible to the patient at the beginning of the test. Now, why would we want to do this? Well, in an extreme case, a patient can walk in with something called tinnitus or tinnitus, that's ringing of the ears, and they might be listening to, all the time unfortunately, a very high level or very loud tone, which might sound close to a pure tone. Now imagine your patient is listening to this tinnitus, they're already listening to these tones in their head, and now we're going to introduce a test tone. So we have to help the patient focus in or lock in on the test tone. So that's why we want the initial tone to be clearly audible to the patient if at all possible. And the test procedure includes a series of ascending runs. So that means we go from a low level to a high level. We use something called a down 10, up 15, and up 5 dB procedure. Now that was specified in the paper. However, today we call it the down 10, up 5 technique. Okay? And then the level at which most of the responses appear, actually that should say the lowest level at which most of the responses appear, at least 50% of the responses, that will be called the threshold. And then from the Carhart-Jurger, I'm quoting them, the initial response of the auditory system at the onset of stimulation is its most vigorous response. The initial reaction is called the on effect. When the stimulus is sustained, the on effect is followed by a reduction in the responsiveness, even though the stimulus is too weak to produce fatigue. This change is known as adaptation, auditory adaptation. So in order to take advantage of this, Carhart and Jurger proposed that the tones should not be continuous. There should be a break in the tone, so we can take advantage of this thing called the initial reaction, or the on effect. The authors recommend, the procedure recommends a silent interval between tones in order to ensure that the relapsed auditory system regains responsiveness. And authors Miller and Rosenbluth showed better thresholds for interrupted stimulus presentations than for continuous presentations. A 5 dB ascending step size is selected in order to reduce test variability and to yield essentially equivalent findings for subjects with normal hearing. Okay, looking at the Kramer textbook, audiometry is the measurement of the ability to hear various tones. A pure tone threshold is the lowest sound pressure level of a pure tone to which an individual responds at least 50% of the time. Generally, the range of pure tone test frequencies is from 250 to 8,000 Hertz. Pure tone thresholds may also be useful when determining how a patient's hearing loss might relate to his or her ability to hear different speech sounds. Here's an audiogram with this thing that looks like a banana, and that thing is called a banana. Specifically, it's called a speech banana. Recall that the audiogram, for the y-axis, we have something analogous to soft sounds at the top of the graph, something analogous to loud sounds at the bottom of the graph. Off to the left, we have something analogous to low-pitched sounds, and off to the right, we have something analogous to high-pitched sounds. 262 Hertz would represent middle C on the piano, and that's close to 250 Hertz on the audiogram, just for a point of reference. So when we say we're going to test low frequencies now, 250 Hertz is actually right around middle C. And then on our speech banana, we have a representation of average conversational speech, and you see it's we have most of the vowel information off to the left in the lower frequencies, and most of the voiceless fricative frequency content will be in the high frequencies. So this is a picture that you should keep in mind as you review audiograms. So picture that speech banana over here in this zone right here. This yellow line represents the pure tone thresholds. Anything above the level, so when we say above the level of the pure tone threshold, we're talking in this direction. This is above the level of the pure tone threshold here. Anything above that level will be audible to the patient. That's where we're finding these pure tone thresholds. And so if you think of the speech banana, how much of the speech sounds will be audible for this person with normal pure tone thresholds? Will it be like half of the speech sounds? None of the speech sounds? What do you think? So picture the banana, and the speech banana is above the level of the pure tone thresholds, and actually we would say that 100% of the speech sounds are audible to the patient. Well, that's really good to know. And generally, when a pure tone threshold is less than or equal to 20 to 25 dB HL, that represents normal pure tone sensitivity or normal pure tone thresholds. Now, this is an audiogram that shows an early noise-induced hearing loss. Notice that the pure tone thresholds are poor right around 4,000 hertz. Now, why do you think it is that this patient has decreased hearing at 4,000 hertz? Well, we have a tip-off on the title of the slide. It says it's noise-induced. But if it's so, evidently this person was exposed to high levels of sound. But why is the damage here greatest at 4,000 hertz? Why do you think? So you may have gotten it if you remembered from your hearing science course. We talked about the ear canal resonance. And the ear canal resonance acts as an amplifier to amplify sounds in roughly the 3,000 to 6,000 hertz region. That amplification then will focus the damage in the 3,000 to 6,000 hertz region. And so this notch is due to, yes, it's due to exposure to high levels of sound, coupled with the amplification provided by the ear canal resonance, which may peak out at a level as much as 20 dB. So if you have a sound at 4,000 hertz, let's say just outside the ear, the sound is at 80 dB. If you have a 20 dB gain provided by the ear canal resonance, now that sound will be how much at the eardrum? Right, the sound is 80 dB on the outside, plus a 20 dB gain provided by the ear canal resonance. Now we have the sound will be 100 dB at the eardrum, and we can call it 100 dB SPL. So, how does this relate to the perception of speech? Well, think about that speech banana. How much of that speech signal, or the components of the speech signal, will be inaudible to the patient? Well, a little bit of them will be in the high frequencies. What about this? So this is called a moderate to severe noise-induced hearing loss. Think about that speech banana, and now you get a picture of what this patient might be hearing. So this patient will miss some of the voiceless fricatives in the speech, but the vowel information will be audible to this patient. So in this example, the noise notch extends to 60 dB. Again, what is the cause of the noise notch? It's the ear canal resonance. Again, ear canal resonance coupled with exposure to high levels of sound. Over time, now we have a deeper notch, so the damage is being focused right there in that region, right around 4,000 hertz. And then when we ask the question, what is the significance of this type of loss? You can say, well, this will affect speech reception, or speech intelligibility it's called, or speech recognition it is also called. And in this example, a patient that has a hearing loss like this They might say something like this: you know, you don't have to shout at me. I can hear you. I just don't understand you. So the patient can hear the vowels very clearly, and for the most part, but the consonant information is missing to some degree. In this case, speech, at least conversational speech and softer speech, will sound muddy or muffled. Now here is a profound noise-induced hearing loss. Think of that speech banana. Now how much of the speech sounds will be inaudible to our patient? Wow, it's actually a lot, and most likely it will affect the perception of some vowels. For example, an E, the sound E, will sound more like eh, because the patient will not be able to hear some of the higher frequency formats in the speech production. Certainly, the voiceless fricatives will be gone, so a loss like this for conversational speech will sound mostly something like this. So, hi, how are you doing? Are you doing okay? Ah, ooh, ee, ah, ooh, ee, ah, ooh, ee. So the hearing loss of this individual acts like a low-pass filter, meaning that the low-frequency sounds are received by the patient, but the high-frequency sounds are not. And even with amplification, this patient might have a hard time hearing high-frequency sounds. Okay, pure tone audiometry continued. Pure tone thresholds are used by audiologists and to describe the amount of the patient's hearing loss relative to pure tone thresholds, determine which parts of the auditory system are contributing to the hearing loss, and determine if a medical referral is needed. Also to predict how the patient's hearing loss may relate to the ability to recognize speech. There are three types of audiometers. One is called a diagnostic or clinical audiometer, may be used for a variety of audiological tests. There are two separate channels. There's channel 1, channel 2. You can also think of it as the left channel and the right channel. A screening audiometer, which only uses pure tones to measure hearing. It's typically portable, used only in the field as opposed to the clinic. And then we have an automatic audiometer. That's an audiometer that automatically changes the presentation levels based on the patient's response. It's very commonly used in hearing conservation practices. I've attended several conferences called the National Association of Music Merchants. And at that show, I've been part of a group from the House Ear Institute, now called the House Research Institute, and we will test pure tone thresholds, for up to about 800 people using this test truck that's using an automated audiometer. And every 15 minutes, 8 people will go into the test truck, put on headphones, grab a button, and push the button each time they hear the tone, and then there's 8 computers in there automatically adjusting the level. So if the patient hears the tone, the computer will decrease the presentation of the next tone. If the patient doesn't hear the tone, then the computer will elevate the presentation of the next tone, looking for the threshold or the lowest level where the patient responds at least 50% of the time. So those are the three types of audiometer. The diagnostic or clinical audiometer has a lot of features. They're usually relatively large, and you can do quite a few different tests with those. In Kramer, in Table 4, it lists the basic components of the audiometer. These include a frequency selector. That is a dial that helps you to select the frequency of the pure tone. An attenuator dial that changes the level. A transducer selector that selects how the signal is delivered through earphones, through supraoral earphones, circumoral earphones, insert phones, bone conduction vibrator, or a Soundfield speaker. There's a router switch, so that directs the signal to the desired location. You can take a tone from channel 1 and deliver it to the right ear or the left ear, etc. there's something called an interrupter switch, which is kind of a funny name for this thing, but that's basically the button that the audiologist presses to deliver the sound to the patient. And then there's a patient response indicator, and that is usually a light on the audiometer. Every time the patient pushes the button, the audiologist will see the light flash. And something called a VU meter. I think that means volume units meter. And this is a meter that shows the output of the test sounds that are delivered to the patient. There are several transducers. The transducers used for audiological testing include insert earphones, supra-oral earphones. There are also high-frequency earphones, speakers, Soundfield speakers, and a bone conduction vibrator. And you should write this down. A high-frequency earphone is also called a circumoral earphone. Circumoral means that the pad goes around the ear. Supraoral means that the pad goes, sits right on top of the ear, if you will. Okay, insert earphones were developed in the mid-'80s by Killian, Wilbur, and Goodmanson. They produced a paper in 1985. There's Dr. Mead Killian in the middle of this group of mostly musicians. There is Dr. Vermilio when he had a little bit of hair still. And this was at a jam session at an American Academy of Audiology conference. This is Dr. Chuck Berlin, who's a brilliant jazz pianist. He studied jazz at Juilliard. And this is a local hotshot upright bass player. So we were doing a jazz gig at the American Academy of Audiology conference. Anyway, Dr. Killian is the one who led the development of insert earphones for testing. He has also led the development for a special type of earplug called a musician's earplug, which is a high-quality earplug. Yeah, actually, it's a great invention. Okay, these are the insert earphones, and you can see that they are a plug, a foam plug, with a tube inside the plug. And this tube leads to these plastic boxes that actually house the little speakers. So the sound is delivered through the tube into, or through rather, the plug that rests inside the patient's ear. The foam plug surrounds the opening of a tube that's inserted in the ear. These are actually preferred over supraoral earphones that may cause a partial collapse of the ear canal. So if you have a friend that will let you do this, push on the pin back where the helix is and push it towards the skull while you're looking at the ear canal. And what you'll see in a lot of individuals is that that canal will start to collapse to some degree. That slight closing of the ear canal may result in artificially elevated pure tone thresholds, especially in the high frequencies. So that's a problem. We want to know what the real pure tone thresholds are, not what the fake pure tone thresholds are. So we have to watch out for this condition where we might get a collapsed ear canal. And a collapsed ear canal may result in a high-frequency conductive hearing loss. We'll explain more about what a conductive hearing loss is in some future slides here. Insert phones are also preferred when masking of the non-test ear is required. Masking is a type of noise that's introduced into the non-test ear in order to conduct a test of the test ear. This is not required for all patients, but for some patients under certain conditions, we will need to introduce masking noise into the non-test ear. When you have to do this masking protocol, it's actually advantageous to use insert earphones. And we'll discuss more the reasoning behind that. Supraoral earphones. So here's a set of supraoral earphones. There's actually this rubber ring that goes around these very ancient earphones that are still in use. And here's this old 1940s radio operator headband. So these phones are still used in clinics. And these are actually preferred when there are problems with using insert phones. For example, if there is ear canal drainage from a severe infection in the external canal, or irritated canal walls. If a patient uses Q-tips routinely, they can create a lot of damage to the lining of the ear canals, in which case we probably shouldn't insert that phone plug, which might be abrasive and actually can cause the ear canal to bleed. So we'll use these old-fashioned supraoral earphones. Of course, the downside, again, is that with this headband, there's going to be pressure on the ears, and in some patients we might find a collapsed ear canal. So here are some supraoral earphones on a very happy patient. Here's the audiologist. You see the patient is actually holding the switch or the button, and supraoral earphones have a headband designed to produce a specific tension. This tension or pressure is also used during the calibration of these earphones. Here is a calibration device. This is actually in our lab at CSUN, and I borrowed this equipment from my colleagues in my old lab at the House Ear Clinic, House Ear Institute. This is called a coupler right here, and a microphone resides in that coupler, and it is measuring the output of this earphone. Notice that this is blue. That's the left earphone. The right earphone has red coloring to it. And this is a 500-gram weight that's putting pressure on this earphone. So that is to simulate the tension or pressure required by the American National Standards Institute standard for headphone calibration. And then here is the the coupler with this ring removed. And what we see here is the microphone, and then this ring goes on top of the microphone, and then the earphone goes on top of the ring, and then the weight goes on top of that. This is a calibrator. The job of this calibrator is you place the calibrator on this mic, and it delivers a tone of 1,000 hertz at 94 dB SPL. That's the whole purpose of this calibrator, which is actually extremely expensive. Here's another shot of the calibrator with the ring on top. You see the left earphone and the right earphone. And then here we have a bird's eye view of the calibrator. So you have this airspace right here. There's the protecting, there's the grill that protects the diaphragm of the microphone. And then next we put the earphone on top. And then we add the weight. We present a tone. And then we measure the output on this, in this case, a very old Brühl and Kjær from Copenhagen sound level meter. And this equipment is just all really, really expensive stuff. So anyway, we'll measure the output on this, and we'll move these buttons to determine the sound level in dB SPL, or we might push this filter right here that's called this button for an A-weighted filter. We can measure the sound in dBA. Okay, when the diaphragm of the earphone is not centered on the ear canal, the high-frequency test tones may be blocked and reduced in level to some degree. So it's very important that we position the earphones on the patient's head correctly. For some patients with supraoral earphones, a supraoral earphone may cause a partial collapse of the canal. We already discussed this, so you know why, because we're actually moving the cartilage, which may result in artificially elevated, poor, high-frequency air conduction thresholds. This is the ultra high-frequency earphone, also called a circumoral earphone, because the padding right around here goes around the pinna, so that's why it's called a circumoral earphone. So this is not a supraoral earphone, and this will be used to deliver audiometric test frequencies, 125 hertz, 250, 500, etc. It'll generate the standard test tones, but it'll also deliver tones above 8,000 hertz, and that's important for certain applications. So this is the Sennheiser HDA 200 circumaural earphones. Soundfield speakers are also called loud speakers, and they are used for soundfield or free-field testing, and they're needed when we test a patient who is wearing hearing aids or for young children who will not tolerate earphones. It's also used for patients wearing a cochlear implant or a bone-anchored hearing aid or any type of device, listening device. An FM system, we could do that. The limitation of testing with a Soundfield speaker is that there is no ear-specific information. When you're wearing earphones or insert phones, we can obtain ear-specific information. What was the threshold for the left ear? What was the threshold for the right ear? But if we do this test in a free field with a Soundfield speaker or a loudspeaker, we cannot get ear-specific information. Soundfield speakers, room acoustics may significantly affect the test signal levels, test norms, and results. The window in this test booth may cause sound reflections that may interfere with the levels of the test signals. So we just have to be aware of that. And okay, here's the Soundfield speakers. Here's the window. So if a window was here versus here versus here versus here, all these, or if there was a desk in a different location, various locations in this room, all those things could affect the presentation levels that reach the patient. Okay, and that's our lecture for pure tone thresholds.